tone, please record your name.
Yeah. Just to let you know,
Has joined the conference.
Dialing in by phone. So you need
the
to
conference.
move the slides forward.
Has joined the conference.
No, Gerard. Just
thank you.
A couple more minutes because everyone take a couple more minutes for everyone else to join. So, apart from those who are presenting for the moment, that'd be great.
The conference. Husbands. Has joined the conference.
We're at past, so I think we can get underway now, and other people can catch up as they join. So I'll just do the introduction. So the third of four evidence summary that we've been running from the Operational Research Evaluation Unit, undertaken by the South East CAU in conjunction with the University of Kent. So the first one, which was on care closer to home, is already available on for people to use on NHS networks. The second one on workforce is we're just waiting for the final documentation, and that will go up to NHS networks. And the final one, which has
joined the conference,
is around contracting. So today we're talking about risk stratification, and we have two people presenting on this. We have Stephen Peckham and Gerard Abbey Haddad. I got that right, Gerard.
Joined the conference.
And so we'll run it is that Stephen and Gerard will go through the slides, and then there'll be opportunity for questions at the end. During the presentation, could I ask that everyone mutes their phones, and can everyone also turn off their videos? Because lovely it is to see people. It takes up quite a lot of the screen. And we'll take some questions from people. There's two ways of doing that. The way we sort of generally seem to have worked with the other two is people a question at the end, because we've tried using it via the text messaging version on the webinar, but it doesn't seem to work. So anyway, without any further ado, I'll let Stephen get on with the presentation. Handing over to you now, Stephen.
Okay, thank you, Gary. Thanks everyone for tuning in to this. What we've to do with this particular presentation is I want to give a bit of a background in thinking about the application of risk stratification. And I'm actually delighted that Gerard from the Public Health Observatory is joining us. What would be useful is actually to go through an example of how it's being used and work being done at the Kent Public Health Observatory on this. And I just think that's a very useful way of just trying to thinking about the process of doing that. So thank you, Gerard. So it's a bit of a double act today. So cover basically is really thinking about what is risk stratification, why we want to stratify the issue of patient segmentation, thinking a bit about the value and robustness of stratification models. And then thinking about
Has joined the conference.
in practice with some guiding principles. It's a little bit of a mix, but I think what we're trying to do is give you a flavour, because like most of these things around
Lee Harding.
evidence, never
Joins the conference.
way of doing things. So risk mitigation is a particularly new idea. The focus is really just trying to think about how you might follow an experience of care patients, ostensibly reducing costs. It goes right back to the 1970s and some of the early work around what is the Kaiser Permanente in the US. I think it's fair to say that as we get more and more
Has joined the conference.
to draw data both from secondary, but in particular from primary care, it does open up new possibilities of thinking about how we can develop and secondly apply such. I think it's not the only way to do things. I mean, we could do one things really. One is to have a model, we have a threshold, which is actually very easy to implement. And we just identify a particular high-risk group or high-risk patients, say, for example, that had for more unplanned admissions in the previous year. All very intuitive, and clearly that'd be a way of identifying risk or highly expensive patients. The thing is, it's not particularly accurate. You would expect those who experience high frequency of hospital in one year to have few admissions the following year, even without intervention. So you're always going to be picking up people that you don't need to pick up. If you're developing an approach, you might say, well, this is a successful approach, but it will dropped off anyway. No way really of knowing necessarily whether it's worked or not. I mean, you have to use professional and clinical competence so that you get the clinicians to decide who are those people who are most at risk. Again, very simple to implement. It's on individual discretion. Of course, what we know is that there are a range of different biases that will creep into this, and clinicians are more likely to identify patients that come immediately to mind and need to do only the patients they know, and therefore not be able to get patients who don't use those services but who might be particularly at risk. And there's another risk that as we get larger and larger combinations of clinicians working to speak patients, then you're less likely to know all the issues related to particular patients. This leads us, in a sense, to the third model, which is that of a predictive risk model. No predictive model is perfectly accurate. There are a lot of problems that are associated with predictive models, and a lot of them talk about is how you actually try and improve the predictive model. But we're looking at 4 different outcomes, of which, of course, we only have the 2 which are correct, so that we correctly identify people at being at risk. That's to do. But if the person is correctly identified as not being at risk, that is, we could also wrongly identify somebody at risk, wrongly identify somebody who's not at risk. Those are always true for any of these models and predictive models. We're looking for a model which obviously through positive and through negative approaches. The first element that we tend to do is to do some kind of patient segmentation. This is that dividing your population into groups, whether it's around characteristics or behavior. For example, one approach might be that's particularly interesting at the moment is the whole issue of polypharmacy, and about, well, what is it around multiple medications which would enable us to identify particular patients who are more likely, for example, to have emergency or adverse effects from the medication. with the whole population, so a macro level, where we want to think about integrating care. So that would be something like Kaiser Permanente. We can population, so we could take a particular long-term condition and look at all patients with diabetes or dementia, or patients that are over age 75, an age approach. We could look for specific individual patients at high risk, perhaps those that are deemed to be high risk of a particular outcome. And generally, we are particularly looking at unplanned admission. And care delivery and policies to be tailored for these particular groups. Now, each different ones require you to use data in completely different ways. How about this? Well, there's something called an impactability assessment, and I think it's quite important that for a Vanguard or as a CCG that you need to think about going through steps to work out whether it's doing something and which approach you might want to use. Just look at a gap analysis. So it's thinking about focusing on attention on high risk patients. We're looking at perhaps that we've got patients with heart failure who are not being offered appropriate medication. Sometimes we want to look at a particular condition, want to look at sensitive conditions to ambulatory care. And again, we can think about heart failure, but we can also think about a number of preventive. For example, asthma would be a good example where there is some evidence of effect. We might exclude the highest risk individuals. This has been done in US healthcare. This is likely to be applicable to the UK system. Might want to exclude individuals who are likely to respond. So you might have programs that exclude the highest risk patients because they're regarded as patients being less vulnerable to preventive care. It might be that those patient groups are more complex and you might want to think about different ways of working with them. So with anything you do, I'm not going to go into all these, but thinking about issues around ethics and equity
Has changed the conference.
Important. Well, the evidence shows, particularly from the US, using hospital data or hospital episode data or the SUS data in England, problems with data provide information on prior utilisation help with predictive models, but actually there are problems with those predictive models. And I think, as Gerard will talk about, including primary care data becomes an important factor. We have weak predictive accuracy, then what will happen is as your sensitivity increases, but as you eliminate, in a sense, more and more, you're actually specifically, that's getting the right people decreases. Often it can become very complex to incorporate longer term horizons. And I think one thing that I would want to say from that is, models tend to explain the whole range or the variability in outcomes. It's a clear limitation. And the work that needed. That was why it'd be very useful, in a sense, to work through an example to show you how it's done. I think also, from my point of view, to actually really say that if you are looking at going down this route, then that drawing on the expertise of people such as Gerard is quite important. And that's a good point to pass over to you, Gerard, to go through the next examples.
Okay. Thanks, Stephen, and thanks also to Jerry for organising the event. Stephen, as you know, I'm not actually plugged in on the web. I'd be asked for the next slide. I'll be following on my desktop copy.
Yeah.
Okay. So, just by way of preamble, my name's Gerard Abiad. I'm Head of Public Health Intelligence at Kent County Council. And I want to just give you, first of all, to kind of sort of contextualize the work we're doing on risk analysis, and also to say that we're not necessarily doing this work particularly from a angle. it's in the context of risk surveillance from a public health perspective. So seeing equal or unequal the distribution of risk is across our patch, and whether we can marry that up with other indicators that note equity and equity. First of all, the Kent context then. Thanks, Stephen.
Yep.
It's a big tool. We've got 12 local authority areas, 7 community groups, just over 1.5 million population. And the health and social care slice of the care cake in Kent is worth around £0.2 billion. Sizable geographically and sizable in monetary terms as well. As with other places up and down the country, we have our fair share of distinct and persistent health qualities, and I'll say a little more about that in the following slides. But also, and especially from a kind of a risk surveillance perspective, also I think are fairly unique in that we have what we've the Kent integrated data set. That's a data set that all at person level, stitched together by pseudonymizing the NHS number of individuals. And in the data set, we have currently around 23 million events that straddle and an emergency, outpatients, inpatients from the sus feeds, care contacts. We have social care going in, and we also have primary care event level data. So for the majority of the practices in our patch, and there are 200 of them, person level data with read coding also flowing in. So all of that data set is stitched together and linked by our third-party provider, our health informatics team. We need them to provide that service for us. We think that that's a very distinct feature of that allows us to do the things that we've been doing. So to bear in mind for your own context as well. And to answer questions, more detailed questions on that as we go through or at the end. In terms of inequalities, next slide, please, Stephen. Thank you. A slide that will be familiar to many of you. We have age standardized rates for 100,000 for all-cause mortality by definition. I think the important thing to note is that inequalities seem to have persisted over years, in fact over decades. While the trend is down, the gap between the most deprived decile, that's the dotted line at the top with the red turquoise circle, and the most deprived, the red line at the bottom, the gap has persisted, although the overall trend is down, the gap has persisted. And really that's called us to question how we can get tangible hold on preventive aspects, especially in primary care, which is to do some of the detailed work on risk stratification. So I'm sorry that this slide is a little bit blurred. I think it may be more clear in the actual presentation. But this is just to give you an idea of our ability to, by the Kent integrated data set, to segment our population in quite a detailed and innovative way. You can see here is, in essence, a multi-morbidity profile from all of our population. There's around 1.3 million, just 1.2 million people, records behind this data set. It simply shows on the on the y-axis, so the vertical axis, the primary diagnosis of the individual from a primary care record, and the proportion of multiply occurring other long-term conditions allied these primary conditions. And basically see that multiple morbidity is a powerful characteristic, especially for people aged 55 and over. But this helps us also to appreciate the need to be much more targeted in terms of public health and conditioning action, in sort of ameliorating the exacerbation of multiple morbidity and making sure that it doesn't end up in individuals in a catastrophic state, because we know that the particular tipping points that when people become excessively multiply morbid, doesn't matter what type of intervention they receive, they're much likely to die prematurely. So again, the focus on targeted risk surveillance at practice level, GP practice level, seen as a very key strategic effort in terms of reducing the impact of multiple morbidity going forward. So, Nate, so we currently use the so-called King's Fund combined predictive model. I'm not sure how many other on the call will have this model, but in fact it was developed by work done by the King's Fund and a group called Health Dialogue and John Billings at New York University. So we
has left the conference.
Essentially adopted this model for our risk score generation and risk load across practices and across individuals across the county. So what is the ambition of the combined predictive model? Well, first of all, focus attention on prevention and illness promotion for those at the relatively low end of the risk spectrum. Secondly, to support self-care interventions for individuals with a moderate risk profile, so less multiple morbidity. Thirdly, to provide an early feed for prevention and care management for people with high risk. And then finally, to identify a very sick end, if you like, of the pyramid, of case management for people with very high risk. Again, public health and a commissioning perspective to segmentation of local population into relative risk segments and to take matching of the intensity of outreach and intervention and risk of unwarranted secondary care utilisation. So in layman's terms, how we divide the population up into risk groups and how we reach them, preferably before they end up as a costly care admission that could perhaps be more effectively managed in the community. And then second to that, to apply the intervention in a targeted fashion and increase the likelihood that patients receive the care that they want. Now, I have to say that the extent that we've been able to do that from a public health perspective has been very limited, and I'll perhaps speak about the reason for that toward the end of the presentation. So how do we construct the combined predictive risk model? First of all, it's been developed by taking a 50% random sample of data from the Care Trust. In fact, they were Croydon and South Warwickshire. And the original modelling work that the risk or the individual variables and their association with an unplanned admission was compared with a 50% random sample for matching, see whether the results were consistent with the other half of the population. And the final population that was used, this population that was used to generate the weights that are used consistently where the King's Fund model is being used, to around 560,000 patients from both these PCTs. So, part of constructing the model, what variables are used? Well, as Stephen touched on, I group these into 5 areas: infant variables, disease conditions has the individual had, what are their admission, non-elective admission utilisation rates, what are the diagnostic cost groups that are associated with those individuals, These are summarised. There are lots more of these instances and contained in the brackets. Secondly, outpatient data, the number of visits, the number of distinct specialty visits, for example, attendance, priority of type, incident location, etc., etc. Accident emergency data is also featured, number of visits, arrival mode, and attendance category. And then importantly, primary care data. So data relating to appliances and equipment that's been dispensed to patients, measurements, for example, HbA1c recording and clinical measurements. And importantly, of course, polypharmacy, an individual on one or more medicines. And as that multiplying effect occurs, so the risk rate increases. And finally, of course, patient characteristics such as age, gender, deprivation. There are a whole heap of others. So the Sun model uses around 123 variables. And as I say, in the original modelling work that was done in Croydon and Warwickshire, those individual variables that passed an a priori assessment for their validity were assessed for a strength of relationship in terms of association with an unplanned admission 12 months from the original cut of the data, and generated a series of weights, which are the used in the modelling work that takes place wherever the model is implemented. So next slide. We're on the slide now, Stephen. Hello.
Yeah.
Okay. So once we receive the weights from the original model, they were then plugged in via our third-party data warehouse people and connected to a matching process, and that process in essence then attaches a cumulative or summary risk score to the individual based on the 123 variables that were contained in the original risk model. And in the original risk model, they reckon that how the pyramid gets sliced up on average. Of course, it varies from population to population. But if you have the very high relative risk group, so the people that probably are characterized by being multimorbid, having a history of high readmission volumes, and they would be suited to the I just got the right-hand slide of the wrong way round. They would be suited to number 4, the intensive care management for high-risk groups. And at the bottom, we've got prevention and wellness group, the lowest risk group. And from a public health perspective, they would be, I guess, more amenable to prevention and wellness promotion for low-risk groups. So that's how the model is, in theory, intended to work. So locally, well, we've done some very basic work to look at unmodeled distribution of risk score in our local population. So this is on all 1.5 million patients or people in our population. And what you can see here is the mean risk score for individuals as they increase in age. And you can see it follows a fairly predictable pattern, with younger age groups, for obvious reasons, having lower risk. But as individuals get older, their conditions and morbidities obviously increase, and so the risk load increases until you get to the sort of very end, which is at the higher end of the age distribution as well. So that's unmodeled. That's the sort of the basic distribution of risk, or distribution of risk that we've been able to give our local Kent data. When we wanted to look at how variable risk score of an individual changes over time. So we've used here exactly the same data, the coefficient of variation, and all that is a measure of the wobble, if you like, the variation in risk score as risk changes over time. The risks are every month, but we have a historical record of an individual's risk, so we can track the variability of risk over time. And once again, as you can see, risk or the variability of risk follows a fairly predictable pattern. In that as you get older, your score oscillates between multiple morbidity levels. But this also could be, we think, an indication of the variability of care, because I guess for multiple morbidity and long-term conditions in general, well-defined national guidelines on how to care for these individuals. The more variable the risk, the more variable potentially the continuity of care. And I'll come on to talk about that in a couple of slides. This is the modelling work that we did, and what we did here is we wanted to see all of the practices in. So each of these littles that you see across the page presents an individual practice. So we have 100 of them across Kent. And what you see here is the odds ratio using a logistic model ratio for the likelihood of having an elevated risk score. And we chose an arbitrary cut-off point, overall median risk, so that of having an elevated risk score for people aged 40 and over as individual practices. And what, in essence, you can see is that that likelihood changes very, very significantly across practices. The roughly just under a tenfold difference degree of variability in having an elevated risk score above practices. Now, one general shape of the curve is of interest. Interest from a public health perspective is that some practices, perhaps at the bad end of the spectrum, we can use a pejorative term, that's on the right-hand side, appear to have, in all terms, a much more elevated... In all terms,
has left the conference.
A much more elevated volume of risk than the left-hand portion of the graph. And so we have tried to use data like this to have a dialogue with practices and just to ask the question, why is the risk load so elevated in your practices relative to other practices? Incidentally, just to note that the data presented in this slide is adjusted for in multiple deprivation, the proportion of people aged 65 and over, the FE of the practice, and whether practice is rural or not. So we've kind of adjusted out potential confounding factors for risk load to have a more open dialogue with GPs. So this is the same principle as the previous slide, only this time the distribution in the variability of risk score. And once see a kind of a good, bad, if I can use those terms, a distribution to risk. On the one hand, practices on the right-hand side of the spectrum having very elevated variability in risk. On the left hand, others hardly any variability. And again, this does raise questions, I think, about the uniformity of the care of people with multiple conditions. And once I try to use information like this to enter in a dialogue with practices at both ends of the spectrum. So in terms of the final slide, or penultimate slide, I think it is. How have we used risk scores to examine the equity of provision of health checks? Well, what you see presented here are 1 and D10, referred to decile 1 and decile 10, so the least versus the most private segment of our population, looking at the distribution of risk for people having a health check and those not having a health check. So this is one way of, on the one hand, getting a handle on whether people in very deprived areas are having their health checks, and whether or not there's a worried well component to that.
Application. And got a 4.5-hour cap. He's put to operate from 8 till 8 on the Anasunda.
Sorry.
But it's just not hospital in it.
So in conclusion, our kind of experience says that risk stratification is a potentially useful tool for identifying preventive public health action, especially pertaining to multiple morbidity prevention and reduction. However, we feel that the current risk strat tool, the King's Fund model that we're using, is probably redundant because the additional risk rates are derived from very different populations. Croydon, South Warwickshire, very old, they're nigh on 10 years old, so the epidemiology of multiple morbidity has changed, and if used in the model are probably underestimating that volume of risk. And there's been an over-reliance on readmission history and insufficient reliance on primary contexts. Also, not all of our practices submit primary care data in terms of the construction of the risk score. There's an asymmetry there which one has to be cognizant of. And a more refined risk strat tool we think we devised by using local data instead of relying on unrepresentative populations. The challenges as we've had is how do you achieve buy-in from primary care, integrated care organisation practice. Very difficult to engage
the conference.
clinical community. And then finally, how do we design a response mechanism to risk surveillance that ensures public health and community engagement? Found, for example, that care doctors are suspicious, if I can use that word, suspicious of predictive risk models. Getting them to look at the data seriously and think about how they're treating multiple morbid people is easier said than done. So that basically summarises the Kent experience.
Gerard, I briefly wanted to finish by actually thinking through some of the more practical steps that you perhaps as Bangor, or whether it's in CCGs or even commissioning support units, going through. So the first is actually just kind of in checklists or what is you're trying to do, and thinking what have you got in place before you
has left the conference.
Strategy. And clearly, I mean, the process that just described is quite complex, quite intensive, and quite both resource and labour intensive. So there is a cost to developing stratification tools. There are a number of tools available for you to use. Gerard really talked about one and kind of some of the problems with, and probably a potential alternative. And it is that, it's a once-off thing, and I think the point about updating data and constantly having the data coming through is quite important. Yes, it's really risk stratification. It's only one part of the process. It's very well having rules, but do need to be considered in the context of, well, what are you going to do to identify people? And, I have to say that the evidence around supporting avoid interventions is not brilliant. I mean, some of the stuff that we do know works are around continuity of care with the GP, during early senior review in accident emergency departments, discharge planning and advanced care planning, coordination of care, for example. The program called GRACE, I'll put this into the actual review, which that you can improve the quality of care and reduce acute admissions. And it's also true that if you're using kind of much more multi-dimensional geriatric assessment, probably thinking a lot more about you work at hospital and the community with older people. That also suggests that there may be some avoidance in hospital admissions. But actually, you know, we're not working here in a very, very robust evidence area. And particularly, as we talked about in the first webinar, some of the questions about the cost ratio on this is not particularly good. How you choose your predictive model, the guide produced by the Nuffield Trust is useful paper, and we will refer to this in terms of thinking what it is that you want to think about, and in particular thinking about what you want to use it for, than just a case of using a tool. You actually need to think about how you're going to use it and what you're using it for, and think about the cost. So these are actually quite important in a sense of procurement and commissioning, when commissioning things around predictive models that you would want to take into account. So briefly, in summary, yes, they are useful in predicting events. They're shown to be superior to other approaches for case finding, particularly using threshold or clinician opinion. What has been previous funding, the department is keen to have an open market, and I think there's about 37 different risk tools out there to tick off the shelf. So I think it's not an easy thing. There's a lot of things to consider. And, you know, perhaps it's quite useful to actually start to think about which models have been started to be tweaked in a sense around the UK to get something that may be more useful. Basically, what you're looking for is cost, accuracy of the prediction, and the availability around what data you're using. I think the point about in Kent having this kind of one data source is quite important. Element of anything that you're going to do around managing patients with chronic illness. It's a decision-making tool. It is not a decision-making in total. So it only if you use it to help your decision-making, but it doesn't provide necessarily the answers that you want to do. And you need to be thinking about other things around hospital avoidance and how you improve health of your local population. And there's a real question mark, and I think this comes right back to what Gerard was discussing about whether you should have kind of useful risk predictive models or whether they need to be tweaked for local, regional, kind of make them more specific to particular areas, so to incorporate local factors from that. That's all I want to say on those. And over to you, Jerry.
Thanks, Gerard. That was right. We've got two ways for asking questions. We've got the chat box actually on the web system, or I'm quite happy to suggest
the conference.
Put questions via the phone. So I will make questions that come through on the chat, and if anyone wants to just ask a question now, then please feel free to.
Nichols here from Dudley. We've used the combined predictive model. We've also used Q admissions. I think it was here that you felt this is a tool within a toolbox that you can use, because some of the sort of problems with admissions, for instance, actually a traditional approach through risk stratification wouldn't have picked them up. So things like your younger age groups with with fever and and tonsillitis being admitted, which might be to do with, sensitivity of decision making, but also confidence in GPs and a whole set of other factors that probably wouldn't be included in an off-the-shelf stratification tool. So we're looking at, as you hinted at the end there, is actually bespoking with stratification for
left the conference.
Each individual practice, because they are so very, very different.
Has left the conference.
I'm not. I seem to be. People seem to be voting with their feet, so I may stop there. But it was just to give an impression of some of the issues and some of the problems. The biggest problem I'm finding is with introduced a risk stratification or regression model or something of that nature, interfacing with people at coalface to actually use it. Because, people at practices, generally speaking, and by and large, you're not going to be working through multicollinearity and those sorts of things. They need help in kind of navigating this sort of stuff and get out of it.
Has left the conference.
I think that, there's something about resource, isn't there, in actually making sense of this. Well,
I think that's right, and I think that was one of the points I think Jared was making about engaging with practices. I mean, research, but also working when before it was actually easy to get data out to practices. If you can produce data in a fairly simple form for practices, they then become quite good, particularly in a comparative form. Not necessarily because, again, it's providing, but allows them to ask questions in relation to the way that other people do it. So if we thought the slide that Gerard put up about variability, that's an easy one. If you kind of strip out and just say, look, these practices have to be very variable at the way they deal with things, and these don't. What is it about those different? And get GPs to do it themselves. But I don't know if you want to say anything else, Gerard.
Yeah. On the two modelled, and Phil out maybe thinking, well, haven't you modelled this twice? You're kind of double modelling data because the original weights were based on generated models.
Stephanie Gibson.
The conference.
The data were modelled in terms of the practice level characteristics, not the individual patient level.
Has left the conference.
So when we presented the data, it wasn't showing the models, because from Dudley's absolutely right. A jobbing practitioner is not going to want to see the out of a regression model. So we're simply asking the question, having adjusted away the confounding factors that may make their practice odd in terms of case mix.
T. Horton.
Have any
Has
idea
left the conference.
why they were on the right or the wrong end of the distribution? But my overall feeling from those engagements, limited as they were, there was a general sort of criticism about analysts light on things that may be going wrong, not presenting the data in that way at all. But I think it's in fact, I've mentioned this to you, Stephen. It would be helpful to think about a more structured mechanism for doing that on neutral territory. How to communicate those findings in an illuminating way rather than in a threatening way.
Has to the conference.
Right, and I think that perhaps for the MCPs, you may have the opportunity, if you are engaged with your practices, to think about both think how and what the models, these kinds of models should do, but about how you might want to put them in practice. So actually, start with the practices rather than start with the model.
Yeah.
the conference.
Stay.
To the conference.
We've got everyone running off now.
Has to the conference.
Other questions
Suzanne Rabbit.
on the phone at all?
To the conference.
Martin from Derbyshire Healthcare.
Left to the conference. Conference.
Okay, sounds like we've not getting any more questions now. So,
Has left to the conference.
thanks, Stephen and Gerard, for their work they've put into this presentation, and also
Lee Harding.
for
To the conference.
review. The final documentation will be sent out towards the end,
Has left to the conference.
like the review document. Thing I would highlight is that there is, within the New Care Models Programme and NHS England, resource to support with using Stratification. So if you want to
Robin Anthony.
I'll be sent out.
Has left to the conference.
On the this question, give you the contact details of the people in NHS England to speak to. Thank you for your time this afternoon, and thank you to Stephen and Gerard. And I will close the presentation now. Thank you.
Thanks very much.
Thank you.
Thanks, Stephen. Bye-bye.
Has left to the conference.
Thank
Has
you.
left to the conference. Has friends. Has friends.
Pauline Preston.